Hello and welcome to Arrhythmia Physiology. The last lesson, if you haven't listened to it, the last lesson was looking at what the waveforms were, how they were made up, and what each characteristics of the waveform meant as far as cardiac contraction, and then looking at general steps that can be taken in interpreting different ECG waveforms. Today we're going to talk about well-known arrhythmias and what it actually means for the heart and what we really need to do about it when we see those arrhythmias. We're going to talk about rhythms that originate within the SA node, because obviously that's the best. Okay, so we have what's known as a normal sinus rhythm. Now when you have a sinus rhythm, it actually means that it just originates in the SA node. If we look at a picture of the heart again, a sinus rhythm just means that it starts in the SA node, it goes through its normal pathway across the atrium to the AV node, down the bundle of His, and the ventricles contract from there. Now if there's a sinus bradycardia, this is happening slowly. Okay, now this generally happens either because you've got a beta blocker on board, okay, so you don't have that beta receptor that's doing that chronotropic effect, so increasing the speed in which the heart contracts, so then you go back to automaticity. So you have a sinus brady. Obviously there's CNS depressant, if you're on drugs, if you've got a head injury, if you've got neurogenic shock, so that pathway's been severed, so you've only got the vagus nerve pathway, which is parasympathetic to stimulate, then these things will cause sinus bradycardia, because you've lost the inherent ability to have that androgenic effect. Now sinus tachycardia is a normal response, okay? Normal response to pain, normal response to needing more oxygen, and it's an all-round normal physiology until it's not. Until you're starting to get sinus tachycardia for no reason at all. Now, if it's sinus, it means that you have a good output. You're always going to have a good output if it's sinus. But as you'll learn that some tachycardias that start sinus can eventually drop the SA. And then all of a sudden you've got like an SVT, which we'll talk about later. Now, when we're dealing with sinus arrhythmias, the main ones are those general, irregular sinus rhythms. You have a sinus rhythm, it's no problem at all, but then all of a sudden it speeds up and it slows down, it's caffeine sort of regulated, so you're getting this triple beat, then stop, and then you're cardiac standstill. All these still sinus, but they're arrhythmias. So if you have, now not ectopic beats, but if you miss a beat, miss a couple of beats, or if your beats randomly speed up, and that's what's known as a sinus arrhythmia. As long as you have the presence of a P wave following a QRS, you can call it a sinus rhythm, and then it's just up to rate and rhythm that will determine how we talk about the rest of the characteristics, brady, tachy, or arrhythmias. Looking at atrial problems. Now, atrial problems are obviously all focused starting either in the SA node, so no relation to the AV and then beyond, except for the case of supraventricular tachycardia. Now this one confuses people. Now the way SVT generally works, now there's a couple of different versions of SVT, but generally speaking, SVT will start in the AV node, okay, and then it sends a signal back either directly to the SA node, that sends a signal straight back to the AV, that goes back to the SA, down to the AV, and you have this circle motion of currency happening. So that's where you get that tachycardia from, because you've got the impulse starting at the AV node, causes a contraction, and then a secondary impulse happening from the from the SA node that causes a contraction, and so on and so forth. So that's a part. Now generally, that's the way they work. You have like a circular one, you can also have a re-entrant one, but generally speaking, supraventricular will start within the atrium somewhere, go to the AV node itself, and start your contraction rapidly. Now, that falls into the algorithms of your narrow complex tachycardias, okay, which we'll talk about during the next lessons. I'm not going to dwell too much on the treatment of SVT because it's quite full on, but that's essentially the physiology of what's happening when we're dealing with SVT. So it's supraventricular, which means it begins above the ventricles. So it's not a ventricular problem, it's an atrial problem. Next is we've got our junctional arrhythmias. A junctional arrhythmia essentially means anything that starts in the AV, okay, because it's a junctional problem. So the rhythm is not starting in the SA node. So you can have three different types of junctional arrhythmias. You'll see that some of them will have what looks like a depressed P wave. Now the reason that's happening is because it starts in the AV and then it moves up and it contracts the atriums, but it causes atrial depolarization backwards to its normal pathway, therefore you get it upside down. Now other times this pathway can take time before you get the atrial contraction, so sometimes the atrial contraction happens at the same time as the ventricle depolarization, so you won't see any evidence of an inverted P wave. If this conduction pathway is slow, you'll actually see evidence of what looks like ST depression, okay, but it looks like a perfect inverted P wave ST depression, which is not normal. Okay, and that, in the absence of a P wave at the start, you've got an upside down P wave at the end that looks like ST depression. That's actually a junctional arrhythmia. It's starting in the atrium, but the pathway for the atrium contraction is delayed. It happens after the polarization of the ventricles. Okay, but all three of those examples are still a junctional rhythm. Now, junctional rhythms are generally slow, okay, because obviously they're working off the automaticity of the AV node. Okay, they haven't got the automaticity of the SA node, so they're generally around your 40 to 60 beats. So they're known as a bradycardia rhythm. You can't call it sinus bradycardia because it's not starting in the SA. Next thing we're going to talk about is other atrial rhythms. So that is obviously atrial flutter and atrial fibrillation. So atrial fibrillation essentially is, if you look at the atrium itself, they're essentially just fibrillating. They're not contracting, they're not doing anything worthy. Okay, now the problem that this causes, both atrial fibrillation and atrial flutter, is it decreases the amount of preload that actually goes into the ventricles to be pumped out into the lungs or into the body itself. So atrial filling normally contributes about 30% of the total stroke volume within the heart. So any atrial fibrillation, you can have around a 30% reduction in your stroke volume. Okay, now this ranges between 10 and 50%, but generally speaking, it's 30% reduction. The way to tell the difference is atrial fibrillation is just no proper P waves. There's just a lot of activity, a lot of milliamp activity before a QRF complex. As opposed to atrial flutter, which it looks like we've got varying morphologies of P waves and then a QRS, and then again varying P waves and then another QRS, because it's not a proper contraction of a P wave. You actually have multi-sites that contract, but the atrium do have some form of contraction with the flutter. So with the flutter you can get some atrial filling, but still it's not enough. Okay, it's not enough to be a true stroke volume. Now most of the time these two are asymptomatic, so they only need to have anything done with them, like cardioversion or medication to control the rate, if it's actually becoming a problem for the patient. Next arrhythmias we'll look at, we'll move from the atria and we'll move down to the ventricles. Now ventricular arrhythmias obviously have more of a profound effect on output. So the first one we'll look at is obviously PVCs, because essentially what it is you'll have a rhythm and then every now and then you'll get a widened, generally, QRS complex. Now the reason it's a widened QRS complex as opposed to a nice narrow one is because it doesn't start in the AV node, so it's not following that beautiful pathways of bundle or hist around the Purkinje fibers. It randomly starts around the ventricle. So if you look at the ventricle walls, sometimes in the bundle, in the Purkinje fibers, that's where the actual impulse is starting. So that's where the action potential is starting from, and then we get a wave effect in a different direction, sometimes against the QRS or a normal direction QRS, and that's why you get this widened QRS complex, because it's going against the grain. It's not as efficient, not as quick, takes longer to do. Now there's different types of PVCs. You can have a unifocal, and that essentially means that there's one part of the ventricle that has this inherent automaticity, or that is starting this action potential. If you have what's known as multifocal, then it means just that. It means there's multiple sites around the ventricles that are firing off. Now, the way to tell the difference is you'll have PVCs on your rhythm strip, but they'll look different. They'll have different morphologies. So unifocal, same morphology of PVCs, And multifocal, different morphology of PVCs. Now again, PVCs can be benign, can be nothing. Often happens when you have too much caffeine or other stimulants, and it can just happen as well for cases of hypoxia, getting a bit cold. You get these PVCs. Now, when they get bad is when they obviously start stacking up on one another. So couple, triplets, or 5 in a row, then you get a string of PVCs, and it starts to look a little bit more like VT. Okay, and that's not good because it obviously affects output. Okay, you can define PVCs as bigeminy or trigeminy, which essentially means that every 2 beats you get a PVC. That's bigeminy. If you get 3 QRS complexes and then a PVC, that's trigeminy. Okay, and these are just ways of categorizing what sort of PVCs you have. When we look at something a little bit different, which is idioventricular rhythms, means that the action potential is starting somewhere in the Purkinje fibers or the bundle of Hist. Okay, so it's not starting in the AV node, so you have a separate pacemaker that is now kicking in. So it happens when the SA, AV is now kaput, and we have a different area that is starting this ventricular contraction. So as you could imagine, the inherent rate is quite slow. So idioventricular rhythms are very slow. Okay, 15 to 40, very slow. Now you can have output with idioventricular rhythms, okay, because it is still ventricular contraction. It's not strong, it's not beautiful, but you can still have output. Okay, if you don't, then we need to start looking at things like cardiac pacing and that sort of thing. You know, no output or ineffective output is more to the point. No output, and you just do CPR. Ineffective output, and then you can look at things like pacing. Okay, but that's essentially the pathology of what's happening with an idioventricular. Is it's starting somewhere, action potential starting somewhere within the ventricles themselves. Now we've all seen and loved VF and VT. Okay, so we're pretty well versed VF and VT. Okay, because they're our shockable rhythms. Okay, so we know all about it. So VT itself is like a tachycardic version of your PVCs, with a little bit of your idioventricular in there. So essentially it's a rapid rate that is just firing off the ventricles. That's why you have that perfect sawtooth appearance, because the ventricles are contracting. Okay, the problem is they're contracting rapidly, and that's how you get the difference between pulseless and pulsed VT. So someone can have VT with a pulse if the rate is slow enough to allow for preload before the afterload contraction happens. So if they're contracting about 140 VT, 150, even theorized up to 180. Okay, if they got up to that rate, you can have a cardiac output because the ventricles are contracting. As soon as that rate gets too high and the ventricles are contracting and not allowing for adequate preload, then that's going to affect the size of the stroke volume, which is going to affect the output, which in turn is going to affect perfusion, and then we start CPR and give them shocks to get it back into a rhythm. So that's VT. You have a single site of the ventricles that is rapidly firing ventricular contractions. As opposed to VF, that's multiple sites within the ventricles. Okay, so it's not like VT where you have that one site and the one pathway happening. This is multiple different pathways, usually contracting against themselves. So if you picture the ventricles and you have different sites around the ventricles that are all engaging their own action potential at their own time, and then they come together, and then all of a sudden you have this fibrillation of the ventricles. So no decent contraction, no chance for cardiac output, okay, because it's just shivering or shuddering. Okay, that's all the cardiac muscle is doing. Okay, so VF looks a lot like Torsades de Point, polymorphic VT, because essentially you have widened milliamp activity and then you'll have narrowing milliamp activity, and it almost looks like it twists around what could be seen as the isometric line. Okay, so Torsades de Point is caused by a prolonged QT interval. Okay, so that's the actual causative agent, is it's having a very, very long, drawn-out polarized and depolarized state with a bunch of fibrillation in there. So as far as effectiveness goes, it's not very effective. Now, Torsades de Point is also a shockable rhythm, but the difference with it is it doesn't fit into the adult algorithm, because if you give it something like amiodarone, which prolongs the QT interval, you obviously make it a hell of a lot worse. Okay, so the treatment is magnesium sulfate, and that helps stabilizes our Torsades de point. Okay, which is why it's often kept to the side of the actual ALS organ, but it most certainly is a shockable rhythm. Next problems that we can have is what's known as conductive abnormalities, and this is when our heart blocks come in. Basically focuses on the degrade of a message between the AV and the SA node, and depending on how that degradation is interpreted will give us a different degree of heart block. Okay, now realistically the first couple there, well, they are what they are. You know, they can be asymptomatic, don't really have to do too much. Okay, but as you start getting on to worsening type 2s and type 3s, then you can have real effects on cardiac output. Now, what some people find helpful is this heart poem. Okay, so if you like poems and you're having trouble ascertaining the difference between the heart blocks, because if you don't play with it, it can be difficult. A first degree heart block essentially says if the R is far from the P, then you have a first degree. Longer drop, then you have a winky back. Okay, if some P's don't get through, then you have a Mobitz 2. If P's and Q's do not agree, then you have a third degree. Okay, so that's the poem that's someone's head out, and if it's helpful, then all power to you. Okay, but I'm going to go through the characteristics of each one, and then we'll look at ways to determine the difference between them, but more importantly, what we actually have to do about it if there is a problem. So looking straight at focusing on the SA and the AV node. When we're dealing with a type 1 AV block, all it means is that PR interval that we measured before, so an interval that's supposed to be less than 0.2 of a second, 4 small squares, is longer. Okay, so as soon as you have a longer PR interval than what is considered normal, you can say it has a first degree AV block. Now, as far as interventions go, they're not great. It involves investigation. That's it. It rarely has any effect. People are on this for years, first degree heart blocks, okay? And it just gets monitored, make sure it doesn't get any worse. When we move a little bit further, so the conductivity pathways gets a little bit more degraded, we start moving into Mosbit's type 1, okay, what's known as winky back. Okay, now what happens here is the PR interval progressively gets longer. Okay, so you measure the first one, it's 4 squares, then 5 squares, then 7 squares, and then eventually we'll lose a QRS complex. So we'll have a P wave that sits by itself, no QRS, then another P wave, and then it'll continue on. Now this pattern is the main point. So when you have a pattern of this prolongation and then drop, that is winky back. Okay, so it actually, if you were to measure it over a period of time, you will get the same pattern of 4 squares, 5 squares, 7 squares drop, and it'll just keep going and going and going, and that's the pattern that we're looking for, and that's what's known as Mosbit's type 1, or our winky back. When we move to Mosbit part 2, it essentially means that not every P wave is followed by a QRS. So this is more of your random. Okay, we'll have a constant PR intervals when there is following, but then you'll have a random drop. So unlike the Mosbit's type 1, you have that progressive elongation then drop, Mosbit's type 2 is quite random. So you'll have beautiful, 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 and then break up. Now it's when you get to your type 3, well, that's when you have that 40 years of marriage state, where two people are essentially living together, but they're not communicating, they're not coexisting, there's no relationship whatsoever. So if you look at the P waves and you measure the intervals of the P waves, you will find that the P wave, so the sinoatrial node, is doing its thing at its own rate. It's following its automaticity, no problems at all. And then if you look at the QRS complexes, you'll also find that they're doing their thing. They're following their own rate, okay? But there's no relationship whatsoever. P wave intervals are the same, the QRS intervals are the same, so the rhythm is individually normal, but there is no P wave that follows the QRS. They are both doing their own random thing independent of one another. Now this obviously means that generally, because of the automatic rate, you will generally have a lower ventricular rate than you will a atrial rate. Treatment for it, it's mostly symptomatic. Okay, obviously these people can have output, okay, but then they can lose that output very quickly if the ventricular rate drops, and then you need things like pacing to come involved. Okay, so that's your different heart blocks, and hopefully it's a way to remember each different one because they can be tricky. Okay, that was a quick overview of arrhythmias. Have a practice, but all means go back and practice and think about not only what's happening within the heart, but also how those effects could affect the patient and what sort of things you need to do about it. So the next cardiac podcast that's coming up, hopefully by the end of this week, we'll be focusing on the arrhythmias. Okay, not arrhythmias, but the algorithms for the treatment of cardiac problems. Okay, so that's the focus, and that's what we're hoping to go through. As always, take care.